Next up, we have Jeff Backer, and he's got House File 960.
Transportation bill.
All right, Representative Backer, would you like to move House File 960?
It's a good
Oh,
bill.
we have two amendments. We'd like to move those first. Oh, well, we got to do the motion. I'm sorry. Yes, we'd like to move that. Yes. Sorry.
All right, we'll
I'm ahead of
move
myself.
House File 960 and then move for adoption of House File A1.
Yes, but we also have an A2.
All right, we can move them concurrently, House File A1, A2. Representative Backer.
Yes, thank
the
you,
amendment.
Chair and members. This bill deals with school-linked mental health grants, which was first funded in 2007 at the recommendation of the Minnesota Mental Health Action Group. Knowing that 50% of all adults with mental illness began experiencing symptoms at the age of 14, we know it's very important to reach these students early. The Minnesota model is viewed positively around the country. The funding goes out to the community mental health providers who then works with local schools. They will closely work with the school staff, such as teachers, school support, and other people in the schools. Now, the providers will first bill your insurance, both public and private. The grant funds are used to pay for those activities that are not billable. For example, students that are underinsured or not insured at all. We will, if you also look at, there's a map in your packet. And what this map does is, and we've made great strides in increasing into reaching these students. But currently, if you look way out west where that hump, bump, tip, elbow, nose is, Travers and Stevens are two of the counties that are not serviced. So we would hope that with this additional funding, we would be able to help those students and so forth. So with that, I'm going to turn it over to Sue, who will...
Representative Backer, let's go ahead and adopt both amendments. A1 just removes the delete in page 1, line 7, and inserts $2 million. Is that correct?
That does.
All those in favor of adoption of the A1 amendment, please say aye. Aye. Opposed, no. The A1 amendment is adopted. A2, Representative Backer moves the A2 amendment expanding services to school buildings and districts where school-linked mental health services are available in less than 50% of the school building. That expands it out as Representative Backer has suggested. All those in favor of adoption of the A2 amendment, please say aye.
Aye.
Opposed, no. A2 amendment is adopted. Representative Backer, two-year bill as amended. Ms. Abderholden, welcome to the committee. Please introduce yourself for the record.
Thank you, Mr. Chairman, members. Sue Abderholden, Executive Director of NAMI Minnesota, and I'm really thankful to Representative Backer for this bill. As you know, mental illness is a young person's illness. Most of the mental illness develops by the age of 24, so if we wait until they're adults, we have waited too long. The school-linked mental health program in Minnesota is really viewed as a national model because of the way we have set it up. A big thing is that we eliminate barriers to access. So families, whether they're in the metro or rural Minnesota, don't have to worry about transportation. How do I get to the school to get my child to bring them to treatment? They don't have to worry about missing work and actually often losing their jobs. A length of treatment could be 22 weeks. Really hard to take off of work for 22 weeks and pick up your child, bring them to the therapist, and bring them back. Knowing where to go. A lot of families have no idea where to go to access mental health treatment. And then the children are out of school for a longer period of time when you factor in transportation. And then, of course, there's the waiting list. We've created a sustainable model because we bring in private and public insurance as well. We're braiding the funding, so it's not just relying on grant funds. We've estimated that the cost of the grants per student served is $668. So if you think about it, that's a real deal. We evaluate the program. I know you're often talking about what are the outcomes, what happens. We do evaluate. Do they complete their treatment plan? And most of them do. Do they get better? And we actually measure their scores in terms of how they're functioning, and the kids are getting better as well. It's a collaborative model. A lot of school social workers and psychologists are not actually clinicians, but we need to work closely with them. And so we're building on their work and kind of adding this other level of service. And a big thing for families is we've created a firewall between those medical records and the school records. We don't think it's the school's responsibility to actually provide clinical treatment, and so this program really helps. I will say that the program is loved by everyone. I do have a packet with some letters that came in over the weekend. Kids love it, the families love it, the teachers love it, the principals, the superintendents, the mental health providers, and more. The outcomes are excellent. We're actually decreasing suspension rates because kids are getting the help that they need. We're narrowing mental health disparities, which is also good. And frankly, we're just really, truly improving the lives of these students. When the legislature increased the funding in 2013, you can see by the maps that we really did increase the span of the program as well, but we need to do more. We have about 76 districts that have between 1 to 25% of their school buildings with the program, and about 130 have between 26 and 50% of their school buildings. In many schools now, there's actually a waiting list for treatment because, again, it's become very popular and people know it's a way to go for help. One of the problems I learned about on my 40-city tour this fall was that in some areas, some of the programs actually need help with transportation, especially in the very rural areas. So we would also allow these grant programs to be used to pay for transportation in the summer if they need to continue that treatment plan. So again, this is a very successful program, and we've actually brought a parent here today to talk about the impact on her child and her family.
Welcome to the committee. Please introduce yourself for the record and proceed with your testimony.
Hi, thank you. My name is Sasha, and I'm a mother of a 12-year-old daughter who has received services through the past 3 years through this grant. I am also a third grade teacher and have students every year benefit from this grant. Last night I shared with both of my daughters that I was coming here today to speak with you, and my oldest, who struggles and is receiving services through the grant, said, "You have to tell them my story. You have to tell them how this has helped me. And just don't tell them my name, but tell them everything. Tell them how I couldn't get out of the bathroom in the morning because she's been diagnosed with anxiety and OCD. And we would go 8 hours in a day where she would be in the bathroom and we just couldn't get her out. And she struggled from birth, and we would make it beyond one stage or difficulty, and then it would open the door to another difficulty that she had. Her anxieties grew to a traumatic level that affected our home, her self-esteem. She felt she was a bad person. And she would finally, when she'd come out of these traumatic moments, she would be so sorry for what she had done and not understand why she did what she did. And we went through play therapy, we went through physical therapy, we went through chiropractic therapy. We exhausted all of these areas to help her. And it wasn't until we were introduced to this grant through Lighthouse Child and Family Services in Malacca, Minnesota, that we started to see some changes in her. And that was the end of her third grade, the summer before her fourth grade year. And that August, we didn't know how we were going to get her to school on time starting fourth grade because she just would not come to the bathroom. We had to make, or she wouldn't come out of the bathroom. We had to make all of her appointments later in the day. And she did start fourth grade. The first day she made it. The days after, she couldn't make it. She couldn't get out of the bathroom. She just didn't feel right. She didn't feel clean enough. And she did have to spend 21 days in a day treatment center, which cost $25,000 for help. And that helped her because we were able to find what kind of medication she needed that would help her get through this OCD anxiety issues. But the grant and Mandy Anderson that works through Lighthouse has helped her believe in herself and realize that she's okay. There's nothing wrong with her. It's given her the tools that she needs to be successful and to ask for help. And she's not afraid to tell people about the problems that she's gone through, which I think is such an important part of helping the students now at this generation. There isn't that stigma that the other, our generation, my parents' generation has of mental health issues. And she's smart, she has high aspirations, and the support she's given is going to help her so much in her life. And the families that I work with in my classroom and the students that I've seen go through this program and find more success and start feeling more self-esteem, we're changing lives. And mental health issues aren't going to go away. This illness is here, and we've only touched a small portion of the children that we are dealing with that are going to be growing up and are going to be our next generation. And I'm so thankful for this grant. And I hope it can be increased to help more students.
Thank you, Ms. Coring. Are there questions for the bill author or for the testifiers? Oh, I'm sorry. We also have a couple more testifiers to come up. Okay. Sorry about that. We have Tom Belcher and Mark Sander. Welcome to the committee. Please introduce yourself for the record and proceed in whatever order you'd like.
Thank you, Chairman Dean, for the opportunity to testify. My name is Tom Belcher. I'm with Greater Minnesota Family Services. We've been providing school mental health services for over 15 years, the last 8 of which in partnership with DHS as a schooling to mental health grantee. Currently, we serve over 1,200 students a year in 42 buildings in 18 school districts, over 21 counties in Minnesota. The largest districts we serve are St. Cloud and Marshall, but we also serve quite a few smaller districts in southern and western Minnesota, including 2 school districts in Representative Backer's legislative district. Our programming has expanded from 2 to 45 staff people, and the number of schools where we provide service continue to grow. Despite this, there's still a great deal of unmet need. In the past year alone, we've added services in 9 school buildings, and we're in conversations with several others right now. However, our ability to expand services at this point can't continue without additional state funding. Grantees receive a flat amount of funding over our 5-year contract cycle, and additional services eventually become impossible if the funding cannot be increased. The Schooling Mental Health Grant gives kids mental health services in their school environment, which for many is the only place that they would ever receive these services. Many of the schools we serve are in communities with limited or no other mental health resources. Grant services have a positive impact not only on the lives of children as young people, but also improves their achievement as students and future citizens. In addition, the Schooling Mental Health Grant, through the Schooling Mental Health Grant, mental health professionals are able to not only treat children, but also serve as consultants and coaches to help teachers deal with challenging behavior. One of the statistics we're proud of is in the first 2 years of our collaboration with the Marshall School District, there was a 22% reduction in school suspensions. This program helps kids cope with their challenges and keeps them in school so they can learn, and we appreciate any support you might be able to offer. Thank you.
Thank you, Mr. Belcher. Welcome to the committee, Mr. Sander. Please introduce yourself and proceed.
Dear Mr. Chairman, members of the committee, and guests, I'm honored to testify here today. My name is Dr. Mark Sander. I hold a joint position with Hennepin County and the Minneapolis Public Schools. And today I'm testifying on behalf of Hennepin County, the Minneapolis Public Schools, and the Minnesota Association of County Social Service Administrators, MACSA. And they are all in full support of this proposal. In 2005, I helped implement the school mental health program in the Minneapolis Public Schools in 5 school buildings. Today, the program's in 48 schools in Minneapolis and in over 150 schools across Hennepin County. which is an exponential growth since 2008, when we were only in 45 schools in Hennepin County. Much of this growth is due to the school-linked mental health grants. In 2015, the Center for School Mental Health and National Technical Assistance Center for School Mental Health at the University of Maryland recognized our program here as exemplar program, and we've had the pleasure of having the national conference here in 2009, once again recognizing the leader that Minnesota is in school mental health. This past year in Hennepin County, this last school year, the school mental health program has served between 4,000 and 5,000 students that wouldn't have gotten services else, without the program. The School Link Mental Health Program significantly increases access and engagement for students and families. Over 50% of the students that are receiving services for the very first time. Of those students receiving services for the very first time, we found over 40% were found to have be severely emotionally disabled, which means that they were at risk for out-of-home placement within the next year. So these are students and families that were not able to engage in care for whatever reason, but those students had very significant mental illness. We've also found in Minneapolis that we have parents and teachers report significant mental health improvements for students. We've reduced discipline referrals and suspensions and increased student attendance. This past year, while the research was commissioned by the Children's Mental Health Collaborative of Hennepin County to do a qualitative study of school mental health, where we interviewed both school staff and parents. And I want to just point out some interesting findings from the parents. Parents said because the school and the therapist and the parents worked closely together, the parents felt much more connected to their child's school. The parents reported that 76% of the children felt more connected, felt an improved relationship with their school staff. 75% of the children, of the parents reported that their children were more interested in school. 88% reported their children had a greater sense of school belonging. And 75% reported that their child was more involved in school. We know that school connectedness is very closely related to increased academic achievement. We believe that there's a significant need to expand these programs. There are many schools that do not have the program and want it, and many schools that have a therapist that are asking for a second one because of the increased need. This is a very cost-effective way to reach students and families with mental health needs. These programs are critical to improving the outcomes for children and family, especially for families that have difficulty accessing community-based care. Thank you very much for the ability to testify today.
Thank you, Dr. Sander. And we'll go to member questions. Representative Murphy.
Thank you, Mr. Chair, and I appreciate Representative Backer, the intention of this bill, and I'm not sure if this question is for you or for Ms. Abderholden or maybe someone from the Department of Human Services, but I just wanted to ask a question about the distribution of the grants. You gave us this map, which is great, and it shows that there are some parts of the state that either are receiving no grants by county or school district, and some that are receiving very little money, and I'm just curious about how the decisions are being made about where the grant funding is going.
So,
Ms. Abder.
Mr. Chairman, Representative Murphy, so the community mental health providers are the ones who actually apply for the grants, and so they have to have an agreement with their local school districts as well. There are some areas where we know some of the school districts were like, no, we're okay, we don't want to do this, and so then they didn't collaborate with that particular school. We have tried to focus as well on poverty because we know that there's an increase and certainly at risk for developing a mental illness, so that's been part of the strategy as well. But I know there is someone here from the department if they wanted to add on to anything that I've said. Looks like I got that one right. Okay.
And then, Mr.
Representative
Chair, just one follow-up question. Thank you, Ms. Abderholden, for that, and again, for you or for the department as I look at this. And then I wonder if we were to look at a map and overlay the incidence of mental illness among school-age students, if the distribution of the funds would match the demand that we might see in terms of incidence if we're actually through the grant-making process meeting the need that's happening where it is most evident.
Ms. Abderholden.
Mr. Chairman, Representative Murphy, there's an overall prevalence rate of mental illness, 1 in 5 children at any given time. Some will have it more serious, some not. I think that if we looked at that, especially in terms of poverty, just that being one factor, I think we would see that we have a greater concentration of mental health programs in those particular buildings. There are some school districts that have actually put in additional funds because they really see the benefit of the program, and so they've added to their particular schools. I do have a chart that shows which districts have the highest concentration of schooling to mental health programs, and I'd be happy to get that for you.
And thank you, Mr. Chair, and thank you, Ms. Abderholden. I'd love to see that information. Of the school districts, in your experience working with this information, are there other factors besides poverty that are being considered? Are we looking at ACE scores? Are we being able to do some assessment in addition to the factor of poverty that would help guide the grant-making process?
Ms. Abderholden.
Mr. Chairman, Representative Murphy, part of the problem is that the school districts don't have access to diagnostic assessment information, and so they wouldn't be able to actually provide that. I know we've also looked at things like number of children who are in the EBD category of a district, also the use of seclusion restraints, because we know that those children probably have already have a mental illness and need some additional support and help. But aside from that, it becomes kind of difficult because, again, we don't have that information until we get actually into the schools.
Thank you, Mr. Chair.
Representative Liebling.
Thank you, Mr. Chair, and I love this idea, and so far from everything I've heard, it's just gone great, because the idea of breaking down the access barrier is really tremendous, very, very important. So thank you, Representative Backer, for bringing this. I had just a few questions so that I can get a better picture of how this actually works. So, and when Dr. Sander was talking, I just wondered, and I have several questions. Maybe Ms. Abderholden, since you're sitting there right now, you could answer this first. How does the student actually get connected to the provider in the school? Say that this other testifier's daughter is, has a need. Does the teacher make a referral, or how exactly is that working? And then secondly, does the school, I assume the schools are providing space for there to be meetings between the provider and the students during the day? Is that how that's working?
Ms. Abderholden.
Mr. Chairman, Representative Liebling, there should have been a chart in your packet that showed the referral source for students. So 47% were from student services. So that could have been the school counselor, social worker, psychologist, nurse. But 20% was actually from the student or family member, which I think is also important that, a parent recognizes that there's something going on and they need help. But we also have, clearly, primary care providers can refer, general ed teachers, so anyone who's concerned. There is parental permission. I just want to make sure everyone knows that. We're not treating kids without families' permission. But anyone can refer if they're concerned about a particular student. The school building does provide space, and it has actually been very helpful for the mental health professionals to be in the building to see the child in their own milieu and how they're interacting and things like that, which is different than when they come into your clinic down the street or 60 miles away.
And then, Mr.
Representative Liebling.
Chair, thank you. And then the other question that I initially was going to address to Dr. Sander is, how many children can a provider see in a day? I assume that some of them might just be there for a few hours, but I imagine if there's need, they could stay there all day and spend their entire workday in the school. And then how many children would they normally see if that was the case?
Not enough.
Dr. Sander.
Thank you, Mr. Chairman, Representative. So I think it varies a lot in terms of kind of where we are and kind of what the workforce issues are, and availability. Like in Minneapolis, we have a full-time therapist at a school. So they're there 40 hours a week, and that's basically their office. And so typically, and then it also will vary a little bit by elementary, middle, and high school. Elementary age students, we're in elementary school, they might be seeing 30 to 40 students a year. And so maybe seeing about 20 to 25 students a week, depending on kind of how long they need to be seen for. And the other nice thing about being on site at the school is you can see them for 20 or 30 minutes rather than an hour-long appointment. And at the younger ages, sometimes having that more frequent connection with the therapist can really actually speed kind of treatment along and skill acquisition. In the high schools, they tend to see more students, so they might be seeing 80 students a year. To kind of depending on kind of what's going on. So I think that you're absolutely right. The length of time, they could spend a whole day there. I know a lot of times for most agencies, they have somebody there at least a minimum of a day a week. And sometimes you just kind of depending on the workforce, it could be and need, full-time. I think to your earlier question about kind of how families get connected, I think a lot of schools will go through their student support team, a teacher or anybody can raise a concern. They go to them so that the school employed mental health professionals that might be able to provide a lower level of service can go, oh wait, no, I'm working with this student. Or going, you know what, I really do think this student really needs clinical treatment, and they can reach out to the family and make the connection and get the therapist and the family connected, so.
Ms. Abderholden.
Mr. Chairman, if I could add to Representative Liebling, I was actually in Duluth this morning and last night, and one of the things that they're looking at with Carleton County and the Fond du Lac Reservation is they're actually using telemedicine in some of the schools as well, so that when you have kind of a shortage of mental health professionals, you don't necessarily want them on the road, and they're actually using telemedicine, and that's actually working very well to connect to students as well.
Thank you.
Thank you, Mr. Chair. Just a quick comment. I think this is really so valuable. I really hope that we can fund this because it just seems like this is kind of the sort of thing where we really get bang for our buck, so to speak. And intervening early, we can just save so much in terms of disability, lives, not to mention dollars down the road. And it's just such an efficient way to get more out of our workforce, really, if you've got, not so much travel time, not so much in-between time and all that. It just seems like a win-win. Thank you.
Representative Considine.
Thank you, Mr. Chair. I guess I have some questions about how the services are delivered. So am I correct in that the therapists are not there all day? They just come in, meet with the child, and leave?
Dr. Sander.
Sure. Mr. Chair, Representative, no, I think in most cases, the therapist is there at a minimum of probably all day. And so they're not coming. So they're there. In an ideal situation, they're going to be there, half-time or more until they can really get integrated. And part of what the grant funds help do is really allow them to be better integrated with the school staff so they can consult with teachers. So I'm working with Johnny. I've learned a wonderful way to kind of help him manage his anxiety. I go and come to you, the teacher, and say, hey, here's some tricks that we've learned to help Johnny manage his anxiety in your classroom. And so then not only do you get to help Johnny, but now you've got more information about how to help other students with anxiety. So they're not just dropping in to see a client and then leaving. They're really there, ideally, half-time or more, to really be able to integrate and consult with the school-employed mental health professionals, the school social workers and those folks, and the teachers to really embed the service in that environment.
Representative Considine.
And I think that would be important that they become part of the entire school experience. You mentioned, though, that some of the referrals are coming from psychologists and social workers that are in the school. Why aren't they providing these services?
Mr.
Ms.
Chair-
Abderholden.
Mr. Chairman, Representative Considine, because they're not clinical staff. So a lot of school social workers are actually not clinicians. Some of the more metropolitan school districts, they are, but in many areas they're not. And so there is a different licensure for that. And same with school psychologists. So we're actually bringing in people who can do the clinical services. They play a huge role, especially for early kind of intervention and things, but this level is for kids who really need that clinical level.
Okay, I guess I didn't realize that my wife is a school social worker and she's also a clinician, so she actually does provide these services. I was under the impression a lot of the school social workers and psychologists were clinicians.
Mr. Chairman, Representative Considine, the other thing I think to consider in this is why this program is different is that a lot of schools are not billing private insurance for services that they provide. Because this is a mental health provider where they bill all the time, they understand HIPAA, they can do all those kinds of things, it actually brings, additional dollars to the table to really meet more kids' needs. So I think there is a difference there, and we've had some families that really have been concerned about that firewall. In some other states, they actually have the schools hire the clinicians, and families have been concerned about HIPAA and what kind of information gets shared. So I think, we did our model this way so that we could have that firewall and so that we could make sure that we're billing both private and public insurance and not related to the IEP.
Thank you.
Can I
Dr.
respond?
Sander, go ahead.
To Mr. Chairman, Representative Considine. So I think the other piece is the work that your wife is doing is really this early intervention, kind of brief intervention work, which is really important. Because some students, that's all they need, and they're ready to go. And your wife can intervene with them without needing to have parental consent, or they might just talk over the phone, but the family doesn't need to come in, and they can start that work really quickly. And then for that group of students who need a much more intensive kind of clinical level of service, that's what these folks come in. So really what we're doing is filling out the continuum of mental health supports for all students. So individuals, clinical social workers who can do that work in the schools, they can do it, right? Continue to do that work, and we're here to work with those students who have a much higher level need, who really need a clinical diagnosis, a treatment plan, and kind of ongoing parent engagement. So it's really, together, we're able to serve more students and really the whole continuum of students who need service at different levels.
Thank you.
Thank you. Representative Albright.
Thank you, Mr. Chair. And Representative Backer or Ms. Abderholden, I'm not sure who can address this, but I'm looking on lines 1.11 and 1.12 of the bill, and it really speaks to, in terms of while school is in session, I would understand that you probably have bus routes and or other modes of transportation available during the normal course of the school year. But when school is not in session, I'm just wondering, and you mentioned telemedicine and that type of thing, so when it requires the grantee, obviously the school district, to use all available third-party reimbursement sources, is there a hierarchy that you're looking at in terms of how you interact and connect with those individuals, whether it be through telemedicine? Is the school district responsible for sending a bus out and collecting or bringing the student to the school district, or is it a function of the parents providing transportation with mileage reimbursement? I'm just trying to understand what that means in terms of the hierarchy of using all available sources.
Ms. Abderholden.
Mr. Chairman, Representative Albright, so because the school district is busing the child to the school like they normally would, and then the mental health professionals coming into the school to provide that treatment. So we don't have to worry about the school busing the child somewhere else, or the parent having to take off of work to transport that child. And the third-party reimbursement is not for the school, it's actually for the mental health provider. So it could be the, Carver County Mental Health Center is actually, they typically bill Medicaid, Minnesota Care, and private insurance, and they would do that for the children that they treat. They would just automatically do it. So it's not the school district billing. This is our mental health providers actually doing the billing to insurance. And we want them to bill insurance before we use the grant funding.
Thank you. Good clarification.
All right, thank you. And I just had a question, maybe for Dr. Sander and/or Ms. Koenig, just about how we, from when I was a kid, about how mental health was approached in the schools with special ed and counseling and so forth. It's very different from today. and kids are different, they're better, more accepting and that kind of thing, but there's still kind of stigma or some feel a little bit weird about kind of asking for help and getting help, and when do you go during the day and that kind of thing. And is it being integrated in such a way that it feels really normal for kids to do that, and it feels okay to do that? And how do you kind of work that in, number one, and then number two, is that part of a structure that is copied from building to building, or is that kind of case dependent?
Sure, thank you, Mr. Chairman. I think this is a great question, because I think what we've seen over time is having school-based mental health, school-linked mental health in our buildings has really decreased stigma. And so what we have found, and so to address your concerns, I think in elementary schools, I think, students are like, hey, because our therapists get out and they're meeting, they're providing presentations in the classroom, they're being seen in the building, they're like, oh, that person's really nice. And so they want to go, and sure, I'll go see her, and we'll send a pass or different ways that the student feels comfortable and being engaged. But in elementary school, pretty quickly there's no stigma, and actually their friends are wanting to come down and meet with Dr. Mark. I mean, those are some of the issues that come up, I think, more often, is other kids wanting to come and talk. I think in middle school, I think that you can get a little bit more sensitivity, but again, as we've been there, students, again, are feeling very comfortable. I think there's a lot more conversation about mental health, and it's a lot easier, and there's less stigma. But I think still some students are like, you know what, if you could give a pass to my teacher, then I'll, there's ways, and the therapist will work with the students, like, how do you want me to get you a pass, rather than coming to kind of the room to pick them up. And then I think in high school, again, you might have more students, maybe not wanting, like, their teachers to know that they're coming in, but like have a pass, kind of manage that. But over time, what we've seen is much more students wanting to advocate for mental health, having things like the Silver Ribbon Campaign, where they've actually now got a student organization focused on mental health awareness and those kind of conversations. So I think in the beginning, students are like, I don't know, pretty quickly we can allay their fears about, well, keep it private, we can figure out, we can do it however you want to kind of get you the pass to get here. But really over time, it's really a stigma reducer.
All right, anything else? All right, let's see. 960 is laid over for possible inclusion in the omnibus bill. Thank you, Representative Backer, as amended. Thank you for bringing it forward.
Thank you, Chair and members.